Good morning. We are going to get started in just a moment. So particularly to those just outside, we'll welcome you to come on in and take a seat. And we'll get started in just a minute. Thank you.
Probably not the thing you want to do when the cameraman's standing over there. I have never had a problem with embarrassing myself. Well, let's start. All good?
All right. Well, good morning, everyone. Thank you for joining us. What day is this for everyone? Day 2, 3, feels like week 4, but it's been a really great, exciting week. We're really happy to kick off our second day of programming here at the Intercon with this really important conversation in partnership with Amgen. And the backdrop of a lot of conversations this week is, in a resource-constrained environment, how do you do more with less? How do you get more impact? And that really starts with measuring what actually is impactful. And we're going to be talking about that today in a series of conversations. And to help set the stage and kind of talk about why this really is important, I would like to welcome Sean Librand, who's Executive Director for Access to Healthcare at Amgen, to share a few words. Sean, over to you.
Hello, everybody, and welcome on behalf of Amgen to our session Beyond the Numbers, measuring what really matters to strengthening health systems. We have a small team within Amgen which started 3 years ago focusing on low and middle income countries in which we don't have a commercial presence. Our team is called Access to Healthcare, and we're focused very much on health system strengthening first. Although we are a medicines company, medicines are the end of a long chain of changes in healthcare systems in order to help create health outcomes. I'd like to acknowledge many of our partners here today because we work with you not because you're good at counting, but because you're good at doing. So Direct Relief we have as a partner for 5 years for programs in many low and middle income countries. City Cancer Challenge we'll hear from today, who we're also in a 5-year partnership with. UICC, anyone from UIC or ATOM in the room? I certainly have ATOM members here in the room. So the Access to Oncology Medicines Coalition is about so much more than medicines. World Child Cancer, who we partner with on programs in low and middle income countries on Burkitt lymphoma. I'm pretty sure, like me, that all of you aren't in health because you want to count people but change people's lives, and that's why we're here. And that's the point for our session, is that as we thought about the programs that we run, and we never had this before, we wanted to create a measurement and evaluation framework for our team, not just for what we do, but for how we engage with partners. Ultimately, counts do have their place, but measuring outcomes is really what matters to all of us. As I said, we're here to change people's lives, and counts don't change people's lives. So what we wanted to do today was invite a number of our partners to be able to speak about the journey. So Innovations in Health, Duke University helped us with this. We have been focusing on process metrics as well as outcome metrics. And to our partners, we guarantee that while we move through process metrics, what we all really want to know is to measure what matters, and that's health outcomes. So with that, I would like to invite Kate and Alina to the stage for a fireside chat before the major presentation. Thank you very much all for being here. Thank you.
Great. Thank you, Sean. So let's see, we can sit here. So, Alina, thank you so much for joining us. And you're coming from the Duke Global Health Innovation Center. And Sean, I think you teed that up really nicely around, often we are looking at how many patients served, how many medicines delivered, how many beds as the measurement of success, which doesn't actually get to outcomes. So when we're talking about counts versus outcomes, and yes, counts have their place, where do you think that balance is, and how do you differentiate when you're thinking about the data collection perspective, the count side versus the actual outcome results?
Yeah, thank you, Kate. First, it's a pleasure to be here, and I'm so appreciative to Devex and Amgen in particular for the invitation to participate today. It's an excellent question, and maybe before I get there, I just want to note that coming from an academic background, that we very much value rigor in evaluation and in measurement. However, we've also worked for more than a decade in different countries and in different settings, and we know that real-world evaluation can be messy. It can be challenging, and both counts and outcomes are really critical as we're thinking about evaluation. And I think importantly, a framework in place, as Sean mentioned, can really provide that guidepost, to the real-world evaluation that we want to take place. And when we think about frameworks, they really are guidelines and really helping to organize and structure different evaluation processes. But as it relates to counts and outputs, certainly, yes, they have their place. Really importantly, in measuring the progress of your activities, making sure that we really understand, are the activities that we're implementing, happening well, but they're quantifying and really providing us that sort of measure of the direct results. And when it relates to outcomes, what counts are missing are that change that's occurring. So really importantly, we need to understand, if we've screened 10,000 people for diabetes, what is happening to those people? What change has actually occurred as a result of that screening? Are they being referred to care? Are they being treated? We don't know that from just looking at counts.
Yeah, and that's harder too, right? I think you often rely on counts because it's easier to get. So, what are some of the ways you think that you can better measure those outcomes? It's tricky, complex. Sometimes it takes many years before and being able to integrate that into learning and into improving your healthcare system. And finding that balance between the short term, you need to know what's working short term, with the long term, and finding those measurements that again, are tricky and messy, and how do you do that? You're going to solve it right now, right?
No, great question. And I think, again, by having a framework to help you really understand and to put metrics in place that help you to understand the data that you're collecting and really being able to analyze that is really critical. I think when you mention long-term outcomes, yes, that can be measured, in 5 to 10 years perhaps. And I think it is important to remember that there are short-term outcomes that you can measure, and it goes beyond counting. So you can look at, if you run a training program, you can understand how much, knowledge has been gained as a result of that training program. You may want to, refresh knowledge of healthcare workers, and give them assessments and tests, for example, to measure how much knowledge they've been able to retain as a result of that training program. So I think it's important to really look at those short-term measures, if you will. And I think, again, having the right metrics and a structure that can help you measure that change is important.
Yeah, and when you think about being able to integrate that learning, I, in my very early career in development, worked a lot in monitoring evaluation, and we do these big evaluation projects, write a big report. It got put somewhere. I don't know if anyone ever looked at it again. How do you take those learnings and then integrate it into healthcare systems so you are actually learning from them?
Yeah, great question. So I think, for us, when I think about integration in particular, I think of 4 domains of the health system that are really important to getting to those health outcomes. And we think about the innovations or the tools that are being implemented and making sure that they are person-centered. we think about policy and the policies that will empower those health outcomes being in place. We also want to think about financing, and financing not just from a budget perspective and making sure that there's enough money for that activity or for those health outcomes, but we want to think about how to incentivize financing in order to get to those outcomes. And then finally, we also want to think about the system capabilities that are in place and making sure that you have the right trained workforce and the right infrastructure in place. So we want to think about all of those 4 areas being aligned in our measurement approaches. And if you have each of those 4 domains sort of addressed in your activities and your work, then you're, again, able to achieve those better outcomes. And also making sure that not only measuring quantitatively is key, but also thinking about the qualitative metrics as well, and how do you better understand, from those person-centered initiatives, how individuals themselves are feeling about different activities, and making sure that you do have this person-centered approach.
Yeah, and I love that person-centered approach, because having frameworks is great, but being able to adapt them to a local context. Can you talk a little bit about how you can take what might be a framework, a policy that a group like you are working to advise on, but then being able to bring it down to that person, cultural context?
Sure. So it is very much all about context, and I think that the framework, again, is this guidepost for you, but every organization and every program that might be in place needs to take that information, work with the local partners, and really contextualize the metrics. So you could set some general metrics, but they really need to think about, for example, what does the public sector want out of this initiative, and making sure that you're in alignment with public sector goals, and making sure, again, that you are taking that information and making it very specific to the setting that you're in.
And I think a lot of probably groups, people in this room work with different donors and funders, and often what we measure is dictated by what's important to them. And so kind of thinking about advice for donor landscape and how they should be thinking about their measurement frameworks and being able to have them be more adaptable to the local context and more aligned with what the local communities need, the local governments need, and less maybe what the donor thinks they need.
I certainly think it's a balance, and really understanding how we can understand from the public sector, thinking about the government's needs and desires, and sort of matching that to what the partner or the donor is interested in, and finding that common ground, I think, is really important. Also important from a sustainability perspective. So if you are addressing what the national government's needs are or the local government's needs are, then you're ideally setting yourself up for a sustainability of that work that you're implementing.
And so what would be your advice to people in the room? Again, we have different stakeholders coming from different backgrounds, perspectives, on how they might want to think about measurement differently and more of this outcome versus outputs approach.
Absolutely. I mean, you hit the nail on the head. You do need to think about outcomes, and while counts have their place so that you can measure the progress of your work over time, those outcomes are really helping you to understand that change that's occurring and making sure that you are actually having an impact with the work that you're doing.
Well, Elena, thank you so much. And we are going to continue the conversation with our other panelists, but please join me in thanking Elena. So I'm actually going to scoot down here and make sure I leave a mic for someone. Hold on. And so I will invite my next panelists up to the stage. And so we have Diogo Neves, who is the Health Systems and Policy Advisor for City Cancer Challenge. Philip Anderson, Strategy Director, Access to Healthcare at Amgen. Come on up. Dr. Krishna Udakaya Kumar, Director of the Global Health Innovation Center. And do we have Professor Samuel Kaba Orakeya in the room? Director General of Ghana Health Services. Okay, so he might come and join us, and we'll get a little surprise appearance here in a moment. So thank you all so much for joining us. And Philip, I want to start with you again about this counts versus outputs metrics. And so, what are your thoughts on how to better find that balance of these outputs and very specific numbers versus more outcomes? And what are your frameworks for how you approach that?
Yeah, thank you. And thanks you all for joining us this morning. So many times and in the past, we settle on outcomes, numbers, budgets, and how much has been spent into a health system. But then we do this because we intend to achieve a certain outcome. And in framing these programs and objectives, if care is not taken, you may settle on the numbers as your end goal and lose sight of exactly what you want to achieve at the end. Let me share with you a very practical example. And so some work we did in the past in cervical cancer. And one of the key KPIs, the things we're looking at, were how many women have been educated or given the necessary information that they need to drive early screening and referral to a hospital. And in one particular country, this was a very good metric that would work in the capital city because it's urban and the women were independent and they could take up these initiatives on their own. However, in that same country in the north, keeping a KPI on how many women have been educated will never get you to the outcome because these women needed explicit permission by their husbands before they go to screen. And so if you intend to reduce cervical cancer mortality by educating women in that part of the country, you wouldn't achieve your outcome. You would achieve your immediate outcome, but you wouldn't achieve the impact and all, and the mortality will still be high. And so embedding these programs in the context, not just the political and policy context, but getting the community buy-in and getting to learn from what exactly the community understands and behaves helps you achieve the outcomes and the impact that you're looking forward.
Thank you. And we have Director General Rodikaya here. Thank you so much for joining us, coming from Ghana. And so we're talking a bit around measurement in outputs versus outcomes and really making sure that that is done in a local context. And I would love to hear your perspective on how organizations, whether it's private sector, donors, NGOs, can better work with governments to devise these frameworks and be able to make sure that we're measuring in a culturally relevant way and what is actually important for you from a public perspective.
So thank you very much and good morning, distinguished ladies and gentlemen. First of all, I'm representing the Director General. I'm the Director for Technical Coordination at the Ministry of Health. Apparently, probably when he comes, he will join us. And so to start with, first of all, you must have the political buy-in, the political will to be able to implement some of these initiatives that we are talking about. Without political will, it will be very difficult. And so for Ghana, we are lucky to have the political will, total political will. And so identifying, again, to be able to push through some of these things, you need directives, policy directives. And those policy directives, again, we've enacted them and they are available. Then we have a roadmap. And so within the larger, the broad perspective of what we seek to do, we have a medium development plan so that we drew from 2022, and it's a 4-year period. So from 2022 to 2025, we are in the last lap of the first one. The second one will start from 2026 to 2029. And in that, we've spelled out the the roadmap. And so one of the key things we have identified, we've always known that health issues and solutions would not only come from just the Ministry of Health. Yes, Ministry of Health will play a lead role, but we've identified strong collaboration And that's why we also have PPP and the private-public partnership that is embedded in the broader plan that we have in Ghana. And so we've recognized that, and so we are working with a lot of private partners. In fact, to start with, not only private partners, but we have identified that there's a need for a strong collaboration among ministries. Because come to think of even solving the waterborne diseases, Ministry of Health is not responsible for provision of water. It's the Ministry of Water Resources and Sanitation. And that is how we work. So we include them during the consultation and harvesting of ideas. We look at it broadly and to capture those parts. And so today, as we are speaking, one of the things we've realized, particularly from COVID, when it occurred, and we're battling, we're waiting for others to get, have the privilege of getting the vaccine before us, as if we were the secondary, class of this. So we said that, no way, we have to start doing something about it. So we've entered into private partnership with private investors, and we have put up what we call the National Vaccine Institute. And National Vaccine Institute is not Ministry of Health that's doing it. It's a private collaboration. Again, we've entered into private partnership with a number like UNICEF, and we are here participation in the World Health Organization. That's another part of it, technical issues. Then we also have, yesterday I was a panel member looking at the Sanofi and the ACVIA, where we are collaborating with them to build capacity in terms of, first of all, early diagnosis of CRDs and then NCDs. And that is helping a lot because it has proven that it's useful when we are trying to detect, particularly in the children, to detect diabetes cases. With their support, we've been able to train our nurses at the lower level, what we call the community-based health program services at the community level before the district level. So their capacity has been built, and they are able to detect early. And we even have a system where they follow up for those who are insulin dependent, so they know when to go, and also train them to know for their own, good, to know when they are supposed to come, and the mothers what they are to do and what not to do, and also coach them and teach them. I mean, because they are diabetic, to know the eating habits and their diets and all those things. So we have a number of collaboration, having recognized that we cannot do it alone. First of all, there's a budgetary constraint. And secondly, we need technology transfer in terms of building capacity. And so these are all things that we look at and we say that, no, we need stronger collaboration. And particularly today, as we are speaking, apart from the normal, disease like emergency and the normal common, ailment that we are treating, we're also looking at how do we strengthen our system, collaborating with private sector to be able to build stronger system, to be able to respond to the promotion, prevention, curative, rehabilitative, and the last point of view where even at the old age, how to take care of all this. And so we look at all this in and identifying where we need to tap in, the collaboration to be able to go through some of these things. Thank you.
Thank you. And so, Krishna, I would like to talk a little bit about following up the technology. And you have to get the data in that data collection, and that is a challenge. And you want it to be locally generated as possible, but then being able to integrate into broader systems. So can you talk a little bit about how you can tackle that challenge?
So when we talk of data, again, we are very lucky that we identify the importance of data so early. And so what we have done is that we have a very good structure where all data at the lower level are captured at the district level. Then it moves to the regional level and to the national level, what we call the DIMS. So the district information management health system. So it gets to the DIMS, and we also have another one because we have a structure in such a manner that the teaching hospitals are directly under the Ministry of Health. All other hospitals, district, regional, are under the Ghana Health Service. And so if they are using the DIMS, then where do you fit in the tertiary? That's the teaching hospital. And so we also have LIMS. So they feed into the LIMS, and at the national level is captured and it's hosted by the Ghana Health Service. Again, what we have done is that one may ask, so how do you get the private facilities their data? And so what we have done initially, we brought them in. We had a workshop with them to tell them the importance of having data. Data is such an important element that without data, how do you distribute your resources? How do you allocate your resources? Without data, how do you determine your priorities in terms of services? So because of that, we wrote them in and we coached them how to fill in the form and to be captured. And so when we get it, then we at the national level, then we assess and then we use it for our policy implementation and direction. Now, let me come again to the private, health facilities. We have private health facility, and we also have religious health facilities. In fact, it will surprise you to know that the religious health facilities, they serve about 40% of our population. So how can you do this without consideration of their involvement? And so now we treat them as an agency. Ministry of Health treats the religious body because they've come together, and so we treat them as agents. We don't do capacity building without involving them. Otherwise, you'll be leaving out a chunk of those who are playing a major role. But initially, we had difficulty, we have challenges, because for them, the private, they are looking at how do they break even and also make, some profit. And so they didn't really seem to be given importance to it. And we found a way around. So we said, look, we, the Ministry of Health, we have the responsibility of making sure that we regulate your activities. So when you are going to establish a health facility, you come to the Ministry of Health. We have an agency that is responsible for that. Now, that agency is called HEFRA. You have to renew your license after 1 year. So what did we do to push them? Okay, fine. If you refuse and you don't come to give us the data, then when you are coming to renew your license, we won't renew you because you've not complied. And so now they are coming in because you are obliged. If you don't push them, for them, it's secondary. Whilst we think that is very important to us. So we have to find innovative ways in addressing some of these challenges. Of course, there's nothing, like somebody said, that there's nothing impossible unless those people who are handling it are incapable.
Yes,
We
so
think we are
I like
capable.
building in those incentives, whether it's carrots or sticks, and so Krish, I'd like to follow up on that point of the data collection and how you do that, and locally, but also being able to integrate it into broader systems.
Absolutely, I think that's really critical, and it sounds like what the Ghana Health Service and the ministry has put in place is quite advanced relative to what we see in a lot of places, which is really fragmentation. Everybody's capturing a little bit of data here and there, not sharing it, often without a common language, so the way we might define hypertension might actually be different in 3 different programs operating in the same district. And this whole idea of why do we think about monitoring and evaluation is really trying to flip the model. It's not that you go do something and then monitor it and evaluate it afterward and see what happened or not and write a report. It's actually quite the opposite. That's what you start. It's the common language. And if you're going to have a public-private partnership, the way you define common goals is through outcomes. Right? Are we trying to improve the experience of health and health care? Are we trying to improve health outcomes for individuals and populations? If so, how do we define that? And then how do we work backwards to understand what are all the inputs and the activities that are required to achieve our common understanding, and what are going to be the responsibilities of the ministry in policymaking and regulation and financing, And where does the private sector fit in? Where do the local nonprofits and other implementers fit in? Because if you don't have that at the beginning, you certainly won't have it at the end. And what we see in an era where we're all resource constrained, where we're dealing with debt crisis, a reduction in ODA, with all sorts of competing health demands, is if you can't create efficiency, then you really can't achieve the best outcomes and the most impact. And it has to be driven by the idea that we can only have collective impact if we're actually measuring the same thing the same way. And that, all of this is really about the motivation. And if we can get that understanding and really then empower through capacity strengthening programs the ability of local organizations to capture and share high value data, but also create those feedback loops. Because often what we hear from organizations is it's a one-way black hole, that we do a lot of work, we capture all this data, we send it off in some report, never to be seen again. How do we change that model to make sure that what we're creating is transparency, that we're sitting down on a routine basis and creating feedback loops so that it's not evaluating a program at the end, but it's actually creating programs that can adapt along the way. So we understand in 3 months what's working and what's not, and we can adapt what we're doing and have conversations with our public sector colleagues so that we're starting to build trust by sharing data early, and we're starting to speak a common language that can achieve outcomes that we all want.
Thank you. And Diego, I'd love to follow up on that, and from your work in Paraguay, and really thinking about the indicators that matter and how you capture that data, and what has worked for you in your work in Paraguay.
Thank you, and certainly I agree that it's monitoring is not at the end, but it needs to be thought from the onset. In our case, the project really was an access project on with some a basket of essential medicines for breast cancer, but we together with our partners, Amgen Direct Relief, we thought, okay, let's embed some health system strengthening components here based on what the local practitioners have defined. Because it's true that sometimes you do have reporting obligations and people will follow to keep their license or to keep their accreditation. But it's also very true that some of these reporting sometimes are not really accurate because they are seen as an obligation and not seen as a quality improvement measure. So what we've tried to integrate in our program was really, as Krishna said, first define the common language, the common quality indicators, and then work towards those. But from the ongoing, understanding that, let's be frank, health outcomes need time to be measured, and donor-driven projects are time-bound. So you need to focus first on outputs, right? You first focus on what are those outputs that you can realistically achieve within that time frame. This is what we did, but always thinking of how can we embed quality improvement in this project so that by the end of the project, what we leave can be sustained and can be better, and not just we close the project and that's it. So what we did, for instance, in Paraguay was supporting communication within services. So not just reporting to the ministry, which I think is really important, but coordination within the network of within the city and critical services, including pathology and other services that led to reduction of the turnaround time, which, if there's any pathology or oncologists here, understand a really critical quality indicator that provides a good sign that if we manage to deliver a good quality report within time, our patients will have a better chance of for treatment. So those things were embedded from the onset. We were able to measure within the time period of the project, and now are part of the institutional quality metrics because we involve the institutions in defining those metrics. Thank you.
And so all of you have talked about the importance of a partnership in this. And Philip, I want to hear a bit more from you on the role that private sector can play and how you think about this as you are working with, whether it's an NGO or the public institutions.
Yeah, thank you. And to take it up from where Diogo left it, that particularly looking at the project that we did in Paraguay, I think the first thing the public sector or the other stakeholders would worry about is the funding timeline that the private sector brings in. And how then does it get us to the outcomes, which normally takes time. And I think the first thing we should appreciate is that short-term funding has a place that should be acknowledged. And like you said, one is things like providing seed funding, early training, infrastructure developments, and again, bringing forward these assets and skills development that further sustains the program through its life, even if it has to go on till the time of the outcome. Then the place of the private sector, again, beyond just being seen as funders, which sometimes happens, is understanding that we are all shareholders in keeping us all alive. And that is what we all set up to do. That is why we innovate medicines for a company like Amgen, and that is why we go into partnerships with academia and all. We come in and we want to be seen as partners and not, somebody who sits on the outside and just gives money. And so, for instance, when we were working through our programs and designing them, we always tell our partners two things. One, we don't throw medicines and money over the fence and say, go and do whatever you want with it. We want to co-create these projects with you. And that is where partnerships come in. Because before our innovations can be used and used for the right patients, the health systems would have to be ready. The governments would have to be willing to come along. Academia would have to be willing to support us in educating and bringing up the health system. And so the private sector, in summary, is a partner and should be seen as a partner towards the end goal of we all saving lives.
And so, Christian, I'd like to bring you back into, and we've all talked about, monitoring evaluation is like a compliance thing, it seems like, right? And again, it's like you get your report card at the end and like you passed or failed the semester and, there's no turning back, and no chance to go back and improve. So I'd love to hear you talk about the role of academia in that, but also how you can get more real-time data so that you can be learning and improving, but also recognizing that you need time to be able to learn more about these outcomes versus outputs and how you find that balance.
Yeah, some of this I think is around how you frame it. I think the more we talk about monitoring and evaluation, it goes into a very traditional donor-driven bucket of something you have to do, and here's a little bit of your budget to make sure you're capturing something along the way that we can write up in a report. We try to flip that model to say what we're actually talking about is data for decision-making, which totally flips what it is you're talking about. It's not measuring after the fact how well you did. It's actually unlocking the data that's required for decision-making today and moving forward. Some of that means you have to map what's available, try to understand the quality of what's available, and continue to invest up front in the capacity of local organizations to capture and use data effectively. The second thing you have to do is capacitate local research and academic organizations. It shouldn't be a Duke University in the US doing this in Ghana. It should be the University of Ghana, who has quite strong capabilities. And so we build local partnerships to do that, so that part of it is how do we build local capacity, but part of it is you have to create trust in the ecosystem. And having an independent academic source of that data for decision making in a local context can create a strong partnership with the public sector, with the private sector that's coming in, and can over time help to strengthen the work that's done in a local context. So that's the approach that we've been trying to take, is how do you unlock data for decision making? We can capacitate local organizations and empower them and make sure programs are designed in ways that are more reliant on that type of locally developed and accessed data, and that part of what we're building is really the real-time ability. Diogo talked about this from a lens of continuous improvement, We know that the field of improvement science has been doing this for decades. How do we build it into the way we implement every program? What we do in the second quarter should be better than what we did in the first quarter. And the only way we're going to know that is if we actually measured how we did against some sort of targets we set.
And so I'd like to bring back in particular after hearing some of your colleagues here talk about how they're approaching it. And, you know, when you're thinking, whether it's a donor or academia or NGO sector working within public institutions, how would you like to see this be done differently? And, you know, the role that private sector technology innovation can play as part of that.
So thank you very much. I think it's very crucial that we understand that even as we talk about data collection, every data has its objective. And I like the elements of the capacity building aspect because in most cases, even when you are partnering, again, the cardinal word here is the co-creation aspect. And this time, that's what we want to do. Because we don't, even as we are prepared to work with private partners, including those who are prepared to fund, it's not easy for you to come saying that, oh, I want to fund this, I want to fund that. What we want you to do is to together bring us on board to set the agenda. We are part of the beginning. Commonly, we set the agenda and objective. And so we co-create, and then we'll be able to possibly where you are thinking of investing or supporting may not be part of our priorities. So what we want to see differently is the common creation, together identifying the objectives and priorities so that it will be aligned to our major priorities that we want to undertake. That is very crucial. Again, sometimes the partnership is structured in a way that you look at the public and then you determine a specific area that you want to, support. And for Ghana, we have even gone beyond just the private partners. We have even gone a long way to include, the civil society groups that are very vital and they are playing major role. Because why? Public health promotion and education, they are part of it. They are within the community. And in some cases, traditionally in our area, you may not have that experience. But you go to certain communities, and what the chief or the religious leader says, they consider even more important than the president. Because they live with, such person, and the trust is there. And so if you don't involve them, whatever you are doing, you will find it difficult for it to trickle down there. And so, as I said, in funding, we have to look at it holistically, get us on board, and then together we determine which are the priorities that you want, or we want you to come in, or you, as being partner, consider that our priority. Again, whenever we are going into these collaborations and partnership, what is missing is sustainability. You come in as partner, and then we identify a certain project. But what you look at, what mostly they consider is the duration of the funds. So if you begin and you don't build in sustainability or sustainable element into it, at the end of the day, once the fund gets to the end, then that is the end of it. And so we'll be thinking along the line, if we are coming into partnership, how do we sustain it? Even if it is, the funds dwindle down, you should have found a way of integrating it into the existing system. Then that will help. Secondly, I usually campaign for transfer of technology because dependency has shown that it doesn't yield the desired result that we all want. Because you feed me to a certain level, and as somebody said, if you teach me to catch fish, it's better than giving me the fish. That one day when you are out, I won't have fish again to eat. So it's better for us to be taught how to catch the fish, so that you are absent, we can still be able to catch the fish. And so, again, transfer of technology is very vital, and we need it so much. Capacity building is another aspect. Because when we partner, or when we are partnering, and we are amenable, because sometimes you think that, oh, if I resist, or if I want to change, the donors may not want it that way, because they come already prepared in a very rigid manner that is how you are to do it. Otherwise, you are. So sometimes, if you give us the chance to be able to make inputs, probably, the initial thinking of the outcomes of what you are participating in may be even better and yield them more fruitful results.
Yeah, I think you're really getting to the heart of just the challenge of donors and their approach. And Diogo, I'd love to follow up on that point about alignment of priorities. And it sounds great, but I imagine it's very hard to do in practice. And can you talk a little bit about your experience in being able to align those priorities?
Yeah, sure. So it is challenging. It takes time to do this in a participatory manner and engaging and co-creation. Sometimes do not fit the timelines of short project timelines, right? But it's really critical to precisely to think sustainability from the onset. Those are things that will ensure, should ensure that those investments, those actions will endure past the project. And this is always at CCAN, this is something that it's really in our DNA, and we try to embed in every single project. We try to think that how we will look like after CCAN is there, right? We are not there to stay ad eternum in the city. So how to do that? That alignment is really critical. Starts from the ground up is our motto, with engagement of the local practitioners. The local practitioners, the local communities, the patient organizations, to actually define those priorities. We don't go to a city with, this is what you need to be doing. Here is the magic formula. We don't know, we don't have that assumption that we know everything. But we work with them to identify, okay, what are those critical services, and where can we maximize this catalyst of that we can mobilize the private sector partners to actually address those critical barriers. So we try to conciliate the opportunity with the need. And then this is where we bring together. I think one other thing that is really important is to always frame, especially when we work at the service level, pathology, pharmacy, oncology, is to always frame the project within the quality improvement framework, right? So, and also what Krishna said, and I totally agree, is that make data not just for the sake of reporting and generating nice comms products, but actually for decision makers. For decision makers. In the case of Paraguay specifically, the hospital managers, particularly the main cancer institute in the country, through the project, they had access to previously unavailable data. This showed to the decision maker, okay, this now helps me to do my work and to rationalize resources in my own institution and communicate with the Ministry of Health. So this gives a good indication. Again, it's an indication, we cannot say for sure, but this gives a good indication this will be sustained because this talks to the need of that decision maker.
Yeah, thank you. We do want to open up to questions, and we also, if you can submit them through, we have a QR code here through Slido if you want. We also, if you're shy to speak, but we also can take some from the room. But Sean, let's see, do we have any that have come in online already?
We have quite a few either there in the room or online, but I'm going to start with one that at face value might be a little prickly, but it gets to the heart of why we actually went about this measurement and evaluation framework in the first place. All of these discussions are so redundant. Can someone explain what sort of evaluation techniques and variables of interest must be used in LMIC? So I want to say thank you to whoever wrote that question, because that really is the core of the question that we want to answer ourselves. Thank you.
Great. Yeah, so who's going to tackle that one first? Krishna, I see you're
Happy
jumping on
to.
it.
And you're right, this is by no means the first conversation around how do you measure that's happened this week, much less at every one of these conferences. The whole idea, as Alina explained earlier, is if we don't get to common understanding and common approaches, we're going to stay fragmented. In the same way that we have a bunch of vertical programs that on their own have done great, but they haven't led to stronger health systems by and large. All of these efforts to measure things for different donors, and I sympathize with an organization like CCAN. You're probably generating all sorts of different reports for all of the stakeholders that you work with. And you're probably seeing all sorts of reports that all of the local organizations are developing. But what I think is different is not that we have fancy new methods. No, this isn't about that. It's much more, how do we create alignment? And this is a moment when efficiency has become much more important, where we don't have the privilege of wasting a dollar. We don't have the privilege of redundancy. So what's going to drive change is the fact that we must hold ourselves more accountable for outcomes for what we do. We've, all of us, I think, been guilty of a lot of magical thinking that if we go educate a population, if we go help providers, somehow that will lead to better health outcomes, and that's never been the case. We have to better understand what we have to do together, what our part is, and if we can't create the partnerships, then we will not make progress in this new era of health and healthcare around the world. And to us, the only way you get there is by having a common language and aligning it to data. If you don't measure, there's absolutely no way you will understand if you're making progress and how to create more effective and more efficient programs.
Thank you. Sean, did we have another question? Oh, okay, great. We have one right here. Hi.
Thank you very much for the very insightful conversations. I just have a very quick question. As countries and program implementers, I think we often focus very heavily on quantitative indicators, which is great, right, to measure our health system's performance. But we do know that meaningful insights, regarding our work is really grounded in the qualitative, like the patient experience, provider motivation, trust, and all of that, which is actually difficult to quantify. So I think my question is, how are we as countries and implementers, integrating the qualitative aspect of our work, in alignment with, the robust data systems we already have to, make, certain decisions about healthcare. Because whether we like it or not, we must incorporate the voices. We can put in all of the input we want, but, the patient doesn't go back feeling satisfied. The provider doesn't feel motivated. So I think we need to find ways to kind of institutionalize this, or maybe want to hear from you how this is being done.
Yeah, Diogo.
Country level.
Thank you, if I may. I think it's very important reflection, and indeed some of the metrics and our experience in specifically on this project was the creation of these quality committees within hospitals that previously were not present or as frequent towards this quality culture. And sometimes you can identify some quantitative indicators for that, but that quality culture change definitely needs a qualitative element for measurement and a perspective of, okay, those services serve a population. That insight from the patient in terms of quality improvement of the service needs to also come from the patient. So, but that's some.
Yeah, good.
Just to add to what you said and to answer your question, again, we have come to identify the importance of qualitative analysis with regards to patients. So because of that, the ministry has established a Devex for quality improvement care to take care of that, because whether we like it or not, the public is now becoming more educated with the sophisticated applications. They can take a phone, even when they present a case and you are, diagnosing, and they go into these applications and they start asking you questions that you wouldn't believe that, they are real. So the public is becoming more sophisticated, and that we have to be careful and make sure that it's integrated. And that's why we have established that, so that whatever level, we have to be looking at the qualitative aspect in addition to the quantitative aspect, because it's very important, as you pointed out. So this is the way we are going. And like I said, the civil society groups that are into, health, we have what we call in Ghana, Coalition of Civil Organization in Health, constituted, made up of different sectors within the society, about 20. They've come together, and they are very powerful. So anytime we're having any stakeholder meeting, we bring them in and to listen to them, because as I said, these are the feedbacks that you get in order to improve on the services that you are doing. And so, yes, and again, because of the court cases that we are now getting, we are sitting up to make sure that, yes, we improve the qualitative aspect of the services that we are giving. Thank you.
Thank you. Do we have any other, one more question here?
So my question is, can you give us some examples of how you integrate gender into your programs for health system strengthening, including issues such as gender disaggregated data? Thank you.
Yeah, important. Who wants to tackle that one, Krishna?
Okay, so looking at gender integration, as you have pointed out, we don't even look at it as a health issue. Nationally, there's a Ministry of Gender and Children. This is a political decision that is forcing everybody and every, sector to make sure that whatever you are doing, any policy you are implementing, you have the consciousness of integrating or involving women and children. And so it trickles down, to all the levels, because if you don't include, mind you, Ghana, if you look at the population, the demographic, the population of women is 55. A bit more than the half of the population. So if you are crafting policy and you don't have this in mind, definitely it will not work well with you. Again, the president has decided that in his appointment, there's a percentage of appointment that he has reserved for women, just to create the consciousness that whatever you are doing as an appointee, you shouldn't forget that women are involved. And one of our great scholars indicated that if you educate a man, you are educating an individual. But if you educate a woman, you are educating a nation. And that is it for you. Thank you.
Amazing. Any other questions back there, Sean?
Sorry, I did see.
Yeah, and actually, just in the interest of time, let's take maybe just a few more questions in a row, and then we'll just try to tackle those quickly. Yeah.
Just a comment, actually. Julita Road from the Institute of Cancer Policy, King's College London, also on the board of trustees of World Child Cancer, in partnership with Amgen. We've done some systematic reviews on cancer research and in many regions of the world, but our focus on Africa, which shows all of the publications are the outputs are very donor and international driven. I've heard some great stuff today about that starting to change. How can we make sure all of your work, individual, whether it's policy, programs, etc., how can we get that published and pushed out into the community? Because I think we say a lot of good things here in Geneva, and we need to show the detail at the beginning and not just the outcomes of the project, because all that how do you do, you hear everyone wants to know the answers and no one remembers to put that in the paper.
Right, good. Great. Yeah, we'll do one more right here. Oh, yeah, and back, and then we'll get you.
Firstly, I'll have mine of the One Goal Initiative for Governance. What does it take technically? What are the capabilities that are needed in order to have real-time processing, real-time? And for Ghana, which criteria do those religious service providers, health service providers, need to fulfill in order to get credited again the next year?
Great. Let's do one more question and then we'll tackle them. And I think right up here.
Yeah, this is a quick one from Ghana.
Yeah.
I think the panelists spoke about the issue raised, that the quantitatives are robust, but sometimes we are very particular about how patients feel and how providers feel. So in Ghana in 2018, the Ghana Health Ministry of Health, with the support from AMA, African Legal Alliance, developed a community scorecard. That's actually a tool for measuring the quality of healthcare services, about 9 indicators. For instance, how the staff behave, whether the infrastructure is good, whether there are logistics. And this they measure from the committee level. We call it Community Health Management Committee. It sits with the CHIPS, which you talked about, Community Helpline Service, so that they measure our health centers, our hospitals, in terms of the staff and everything. That has been good. That's the community scorecard. Thank you very much.
Thank you. So I'm just going to ask each of you to try to briefly respond to those. And I also think really that important point of how do we take these conversations beyond Geneva and actually make them not redundant and being able to actually see something changing on the ground. And so Diego, I'll start with you.
Thank you. No, I agree with Julie's comment, and I think we need to engage more local academia. We are working with at least us, and we are making a deliberate effort to do that in our programming, to work with more implementation scientists on the ground and use some of these of the project funding to actually support that capacity. Sometimes you do need that seed catalyst funding, some public health groups, research groups in low and middle income countries really need that kickoff support to generate and support because the local health workforce is so strained. They need that support from academia to actually show what they're doing, because they are committed to quality improvement, and that is one way for it to do it.
Not just adding to their list of things to do. Philip.
Thank you. I think for me, to make it easy, I think how do we measure? First of all, you don't get into any program in an LMIC and go with a fixed thinking of I'm going to count numbers, patients, money, how many have trained, how many have fed, how many have moved, but rather have a flexible scale that that has a look back, feedback, where you can tweak and measure as you go along, accepting that there is diverse culture. You need to get acceptance and the buy-in of the public, and then you need to also pay attention to what exactly matters to this health system and how do I move it from one point to the other, and not just how many of what I have done.
Krishna?
Yeah, maybe just two thoughts. One is we absolutely have to invest in building local capacity across the board, whether it's academia, research organizations, local organizations that are implementing, and the public sector, which often has policy implications, but also needs to be capacitated to be able to use data for high quality policy and decision making as well. So how do we invest no matter what program? Because often that's a tough conversation to have with a sponsor or a donor who wants to say, well, if you can either invest in building stronger capacity, or I can increase my numbers to say, oh, you reached 100 more people with that same amount of money. So I think we all have to be aligned that building local capacity has to be a really important part of every program that we design or fund or implement. The second piece is we have to create those feedback loops. So the question in the back about how do we make sure this is available in real time? all of that technology exists. It's not a technical issue. It's very much a political will and a resourcing type of problem. And every time we run a program, right, we bring organizations together, at least on a quarterly basis, to say, let's look at the data we've just generated, make sure we're applying it in visually compelling ways through dashboards and others, but sit down together and try to understand what's happened, where the gaps are, where the opportunities for improvement are. And I think that creates the peer accountability and starts to build trust across organizations that it's not a power dynamic at play here, but rather trying to figure out how we move forward together.
You have the
Thank you
final
very
word.
much. Yes, I think in all this, what we need to avoid is duplication. You know, duplication is not serving us, well. Because you find in some cases where the donors insist that I want to go into malaria control. Yet you have many others that are either handling the mosquito nets, the indoor residual spray, larval source management. And so it becomes a bit nebulous and difficult. So avoiding duplication would really serve us good. Then coming to the standard of the private partnership participation, if I got the question right, we don't have a strict-jacketed standard. But of course, first of all, your entry point is very, very important. If you are coming in to participate, we look at your entry point. Do you have any records? Are you registered, institutions known? And of course, we don't stop doing search on you. Because government will not, allow itself, to be driven through certain trajectory that will not render your partnership or your relationship well. So we'll do the due diligence on the company to see if there's a company. If it's partnership, you should have been known worldwide, and we can trace. And any company that's coming to work in Ghana, of course, you must register. Ownership is very important, the records. And so either you are entering through an agency of the ministry or directly with the ministry. These are all things that you must know. And of course, you can't just go into a country to enter into partnership without finding out what are the rules and regulations, or which way do I get to that. Some will come even through the presidency. So it depends on your level of partnership that you want to build. And that would guide us as to how do we tackle it. So there's no, as I said, there's no strict-jacketed, standard that you should follow A, B, C. But of course, in implementation or in partnership, there's always a guideline that you should. And as I said, you have so many ways to get to participate in it. And again, it's good that when you are coming in, the identification of the gaps is very important. If you don't have that prior knowledge about it, you can always engage, because we do stakeholder partnership, as I said. So in anything that we are doing at the Ministry of Health, we identify which are the other related ministries that can support, so that we don't take because it's Ministry of Health, we must do it, yet you don't have the capacity. You don't have the financial muscle and all those things. So we consider that it's a multi-sectoral, and that's why in Ghana, we are now gearing towards One Health. I'm sure some call it One Health, others call it planetary health. If you call it One Health, you are looking at the human health, the animal health, and the environment. But some are also saying that, no, let us look beyond that. And that's how come they said, let's call it planetary health, because climate change is part of it, and we must include that. So this is how the approach that we are looking at. So the One Health is really helping, because there are a number of ministries that are part in driving, and we have to look at it in that way, because we are talking today as we speak, we are talking about antimicrobial resistance. Now, antimicrobial resistance is not just within the human health, but it's also in the animal health. If you care to know, at least I can speak about Ghana, where you have, the cattle market. And if you go and watch how many, including the owners of the cattle, they inject and they use antibiotics, the same antibiotic that we are using, amoxicillin, oxytetracycline, penicillin, is the same drug that they are using. And sometimes, the residual effect will not finish. And for the local people, once he sees that they are treating and the animal is not getting well, the tendency is that they go to sell it to the butcher. And the butcher will slaughter. The residual, antibiotics are still there. You go and then you are eating it. These are all sources of antimicrobial resistance. So if we don't involve them and we just look at it as a human health issue, we'll be missing the boat. And so that's why we have broadened and we are looking at One Health, which is very, very important.
Yeah, at the end of the day, it's not about measurement being better, it's about global health being better, right? And so thank you all so much for your contributions and giving us both framework, roadmap, and ideas for how we can do this better. Thank you to Amgen for partnering with us on this really important and critical conversation here, and we will continue to be covering this at Devex. Also a reminder, we will be starting our new summit here at 10 a.m., so please stay, but we'll be here for most of the rest of the day. But thank you all for joining, and again, thank you to Amgen.